my name is Khadija, and I am currently doing job in a hospital in Pakistan. So I just want to share a rare disease of Budd-Chiari syndrome. Actually, a rare presentation of Budd-Chiari syndrome. It is like a combination of a patient who had a previous history of abdominal tuberculosis. Along with that, she was pregnant, and it was her postpartum period, and there was a lot of negative systemic findings, which was very rare, as Budd-Chiari syndrome is the obstruction of a portal vein, due to which there is like symptoms of ascites and abdominal pain. Along with that, there is liver enzyme derangement, but in that patient there was nothing like enzyme derangement, or the CBC was normal except for anemia. There are some things like esophageal varices and liver failure and abdominal pain, which are hallmarks for Budd-Chiari syndrome. But in the patient I am discussing, she was a 25-year-old female with 1 month history of abdominal distension, as I had shown in my poster, and there was no systemic findings like there was no skin disease or mouth ulcers, fever, cough, joint pain, photosensitivity, and oral ulcer. There was nothing like that found on that patient. Along with that, the patient had past medical history of abdominal distension and DVT 2 years ago, for which we diagnosed her to be abdominal TB. There was no other significant history of asthma, hepatitis, or diabetes. Then what we did, we went for her lab diagnosis, lab workup. So in the lab workup, we did see a complete blood count. So in that patient, the only significant finding was the anemia. When we did the electrolyte, everything was normal. The liver function tests were significant for elevated alkaline phosphatase, and when we did serum albumin level, the protein, serum albumin, and globulin, everything was normal. Then we did ultrasound of abdomen, and the ultrasound was most significantly shown that the patient had hepatomegaly, splenomegaly, and portal venous pressure. Portal venous pressure was elevated. Along with that, there was enlarged portal vein which is 13 millimeter in that patient. As we already know that normal range for portal vein size is 5 to 8 millimeter, but in that patient it was 13. So this was suggestive for Budd-Chiari syndrome. And when we did the Doppler ultrasound, there was sluggish flow of the blood from the liver portal vein, and there was obstruction in the compression of hepatic inferior vena cava. When we did the CT scan of abdomen, there were found abdominal ascites and the caudate hypertrophy of the liver. Along with that, there was enlargement in the peripheral and central portion of the liver, which was suggestive of obstruction due to hypercoagulability or any other cause, which is like diagnosis for Budd-Chiari syndrome. And when we did esophagoduodenoscopy, there was grade 1 esophageal varices, which is less than 2 millimeter, which was also suggestive for portal hypertension. Portal hypertension is also a hallmark for Budd-Chiari syndrome. So these were the findings, after which we concluded her to be suffering from this disease, but there was no liver enzyme derangement, which was preocular in that case. Along with that, we concluded, we gave her anticoagulant, and after that there was significant improvement in that patient. So I just want to discuss about the treatment plans about Budd-Chiari syndrome patient. Like, first of all, what we should do is do blood analysis, ascitic fluid analysis if there are ascites present, ultrasound of the liver, and Doppler for the portal vein. After that, we should start working on the CT scan if we want to find the exact location or extent of obstruction. If there is positive ascites, esophageal or gastric varices, and liver failure, we start working on the treatment, which is first anticoagulations, which if does not work, then we should go for TIPS, which is creation of shunt from the portal vein to inferior vena cava. Or after, if it is ineffective, then what we should do is to start or try angioplasty or shunt surgery. If there is no improvement, or there is suggestive of patient is suggestive of liver failure, then what we should do is to think about or discuss with the patient about liver transplant. But it is very rare that the patient needs liver transplant if we start working on the patient as early as she or he become symptomatic. Then there are chances that the patient has less irreversible defects, and the patient become cured of her disease with anticoagulant, which is the first line treatment for that patient, or the treatment of Budd-Chiari syndrome. Along with that, I just want to share that we should also make her in we should also schedule follow up for her for any patient suffering from Budd-Chiari syndrome, so that she or he may be early diagnosed. And anyone suffering from past TB history or in postpartum duration, if there is abdominal distension and ascites found in that patient, we should keep Budd-Chiari syndrome in our mind, so that he or she can be treated easily and as soon as possible, so that there is no irreversible uh, derangement in that patient of any organ or end organ damage. In conclusion, I just want to make people aware of the chances of having Budd-Chiari syndrome as a cause of abdominal distension or ascites if the patient is suffering from past history of abdominal TB, and there is patient is in postpartum period, and even if there is negative findings, negative systemic findings like physical findings, except like abdominal distension and ascites, the patient should be at high risk of Budd-Chiari. It should be like discussed about the chances of having Budd-Chiari syndrome, and we should do an abdominal ultrasound. Along with that, we should start workup for diagnosing the Budd-Chiari syndrome like CBC and liver function tests. Even if they come normal, we should think about Doppler ultrasound or CT abdomen, so that we may diagnose the Budd-Chiari syndrome um, at very early stage, and the patient will be recovered easily if we diagnose it early and start treatment with anticoagulation tips or angioplasty, so that there is no liver failure and there is no need of liver transplant, and the patient is treated correctly. So here I want to thank the California Research Institute and Dr. Bernie for giving me the opportunity to share this case and to discuss my case with you all, and hope we all get knowledge about various causes and various diseases through this research seminar. And have a nice day.